So firstly, good evening to everyone. Thanks for joining us on a probably cold Wednesday night, wherever you're joining from. So I'm Dr. Josh Watt, so chairing the Sydney Addiction Seminar for this evening, so our second one for the year. Very excited for tonight's topic. We're going to be discussing the ins and outs of withdrawal management, a discussion of rapid access model for ambulatory withdrawal care, and the relationship with inpatient withdrawal management. So we're very lucky to have two presenters tonight, Dr. Stacey, Weedon and Dr. Craig Sadler. So a welcome and big thanks to them for joining this evening. So by way of brief background, I'm sure they might introduce themselves a little more. Dr. Weedon and Sadler both work within the Hunter New England Drug and Alcohol Service. Their perspective and experience for tonight's topic comes from their work across a range of settings. So particularly the Calvary Mater Hospital outpatient withdrawal clinic, a variety of inpatient CL services, including the Lakeview Belmont inpatient service. So we have a wealth of experience between them across these two settings. And I think it's a very interesting topic. For me, it brings to mind a lot of competing priorities, which we're often thinking about on a day-to-day basis in outpatient settings when we're deciding on disposition. So that's obviously number one being patient preference. Where will the patient go? What will they accept in terms of a disposition setting? But we have to balance that with clinical safety, of course, what we feel is appropriate. And I'm always up for a discussion on what is and isn't appropriate for inpatient versus outpatient. I think that's where the money is. But also resources and what we can manage to provide, thinking about sort of resource justice as well for many other patients that we might have needing services. But for me, I think this is important because we do know from experience that a large number of people simply can't tolerate inpatient settings for a variety of reasons. So there's issues of access to care as well and justice in that sense. So I'm interested to hear tonight about the rapid access side of things, because we know that rapid access style model is associated with good outcomes in a range of areas in drug health, such as opioid treatment. So how that ties into the withdrawal process is going to be fascinating to hear about. Before I hand over to our speakers, I'd like to acknowledge the traditional custodians of country on the lands of which we're meeting tonight, and recognise their continuing connection to land, waters and culture. I'd like to pay my respects to elders past, present, emerging, and also recognise that we're probably meeting on lots of different lands this evening. So a little bit of an idea of some of the land on which we are meeting. We do have a significant representation both interstate and regionally, which is fantastic. So it would be great to sort of hear perspectives from other services outside of the major metropolitan areas as well, when I'm thinking particularly about access to inpatient settings and how that can be resource constraint. And of course, we like to sort of have a little bit of a peek at who might be joining us tonight. And it's always fantastic to see we have such a range of clinicians interested in our seminars and joining to learn more about these topics. So that's the breakdown for tonight's presentation. So without any further delay, I would like to stop sharing my screen and hand over to Dr. Stacey Weedon and Craig Sadler to take the evening away.
Thanks, Joshua. So yeah, welcome everybody. So just a quick introduction. I'm Craig Sadler, so staff specialist, Calvary Mater and for the Hunter New England area, and I work in Western New South Wales monthly as well. And
I'm Stacey. I'm a staff specialist with the Hunter New England and the Mater as well, and I work in a variety of settings in inpatient and outpatient, and providing some distance support to the regional areas for consultation liaison services.
Great. So we'll just attempt to share our slides. And so can everybody see that? Yep, great.
Looks good.
So I'm going to provide the first half, which is a bit of a background about how the unit was set up and functions, and then how we came to develop this rapid access model over the last few years. And then I'll hand over to Stacey to talk about the more interesting stuff, like the types of patients we see and some of the outcomes and numbers of patients and things. So one more time. There we go. Great. So the overview is, so I'll talk about a little bit about our unit, which nominally is called the Alcohol and Drug Unit, Calvary Mater. The services provided within our multidisciplinary team, a bit about the ambulatory withdrawal service and how we can stratify the presentations for withdrawal management that come from across the H&E. A little bit about how COVID affected our thoughts about changing service delivery. What is our rapid access clinic look like? And then outcomes and statistics currently. So the Calvary Mater, so everyone knows, is a 215-bed publicly funded hospital, has a service agreement with Hunter New England for the clinical services. So we're a public hospital. It's owned by the Little Company of Mary, and so founded in 1921 and transferred to the Little Company of Mary. It's part of the Calvary Health Network. And we provide those range of services, the general ED, medicine, and surgery services. We have specialist cancer services for regional New South Wales. We've have the melanoma and breast screen unit, toxicology, tertiary toxicology and palliative care services, as well as our drug and alcohol service. And the Hunter New England mental health inpatient service is on site at the Mater Hospital, run by H&E, but nonetheless on site. And that mental health service also has an outpatient substance use service, which we liaise with. Those are the admissions and outpatient occasions of service numbers. So our particular unit was established in 1983, and if there is anyone older than me on the signed in, they may remember the Drug and Alcohol Directorate funding initially. That went to the Royal Newcastle, as well as Westmead, Prince of Wales, Royal North Shore, RPA, which funded the establishment of drug and alcohol units within the public hospitals. That's where our unit developed from. And in 1991, when John Hunter opened, they forgot that drug and alcohol existed, despite being part of the planning, and hence we were moved to the Mater Hospital. All of that, I'm glad to say, predates me. So we currently have a multidisciplinary team, so essentially one full-time staff specialist. Both Stacey and I have 0.5 for the Mater and 0.5 for the area health service. We have rotating registrars and JMOs and addiction medicine trainees through the service. We have 4.2 nurses, so the NUM, and 3.2 FTVs, which work a 7-day roster. We have most of an OT and a little bit of social work. We did previously have a psychologist. However, we're unable to fill that position with multiple attempts. Hence, we changed the focus to using OT and social work. And we form part of how we operate is we form part of the broader H&E drug and alcohol clinical services. So we basically function within the Mater withdrawal services stream, which includes the Lakeview inpatient unit. But there's a wide range of the normal community and outpatient and OTP services, as well as CL services across the whole of Hunter New England. So what do we do? So we accept referrals for any patient with a drug and alcohol problem, with the exception of opiate treatment, opiate agonist treatment, OTP, where the referral is to start opiate treatment in terms of the longer term treatment. We'll accept the referral from any source, including the patient. And we also have a focus on seeing family members or friends of a patient who has a problem, who has a drug and alcohol problem. That's including even if that patient is not in treatment with us, we will see and assist family and friends with just general information around support to them and how drug and alcohol services and access might assist them. Or help them assist the person in their family with a problem. So we do our withdrawal services, general. So we liaise with GPs to assist them with the mild to moderate group in terms of protocols and schedules and just basic information. We do outpatient withdrawal, which we'll come to. We also here at the Mater do the complex inpatient withdrawal. So the high-end patients with multiple comorbidities, multiple complexities, previous complicated withdrawal where they need multiple teams involved, we will admit here either under drug and alcohol, myself, or jointly with medicine or other surgery or other departments. The mainstream inpatient withdrawal happens through the Lakeview unit, which is at Belmont Hospital, local district hospital, has a 12-bed inpatient medical withdrawal service. So most inpatient withdrawal of all bar the most complex is handled in that setting. We do CL to ED and inpatients, and we do a limited amount of CL to the mental health service on site. They don't have their own drug and alcohol CL service. We have addiction medicine clinics where we do the range of normal sort of treatments, alcohol pharmacotherapy options, chronic pain patients, complex referrals, including complex medical patients with multiple comorbidities, fitness to drive, APRA-related patients, so quite a wide range. We run relapse prevention both individually and group. So often patients that come through our withdrawal service will be linked in with some short to medium term relapse prevention options. Thank you, Richard, for that little note to the group. We also have a women's group and an alcohol relapse prevention group. There's other focused counselling approaches, brief interventions, motivational interviewing, CBT, smoking cessation, some occasional controlled alcohol approaches in select people. It's not something we do a lot of. We have an OT, so there's some cognitive assessments and functional assessments that we can facilitate. There's the prevention and harm minimisation side of what we do with our patients. As I said previously, one-to-one consultations for family or friends of people who have problems. And even though I said at the top that we don't do OT, we do OT in selective patients. So that's Hunter New England staff, patients that come through oncology. It may suit circumstances for us to treat them as opposed to the opiate treatment programs here in Newcastle. And there's a range of other special circumstances that appear to happen. So we have a small group of people on buprenorphine for those reasons that we manage. So the specific withdrawal services. So we fortunately in Hunter New England can take any assessment of the patient, and almost every single time we can decide with the patient and with other services what the most appropriate setting might be. So we can link that to GP assisted withdrawal. We can do ambulatory withdrawal ourselves. We can refer for inpatient treatment at Lakeview. We can continue some completion of withdrawal with post Lakeview admissions, and also some other hospital post admissions. We can admit the highest risk people to the Calvary Mater and undertake the complex withdrawal patients. We can review and liaise and work out plans for acute ED presentations, whether that be here at our hospital or whether that be in some of the other regional hospitals or Hunter New England hospitals. That may be brief admissions, short stay units, stabilisation, transfer to outpatient or transfer to Lakeview. And we're developing telehealth support pathways for those things to exist in Manning and Tamworth as well, where there's much more limited staffing. So that's how our withdrawal sort of process works. So the outpatient withdrawal has always been provided by our service. It used to be more of an ad hoc situation where we would be seeing patients, whichever member of staff, they'd be having an assessment. If assistance with outpatient withdrawal was necessary, then they would be as quickly as possible linked in with one of the medical clinics. And so that often meant that there was just extra people put into clinics that were already booked so that we could start treatment or continue to treat people who'd presented in acute withdrawal. So it's always been done, but it was never particularly systematic. The usual process was to see people several times over the first week, and we have a pharmacy and pathology on site, which were always very helpful to that process. That's what used to happen. Then COVID occurred, as we all know, and we all had to think about what we do differently. So at the time, we changed our model to provide telehealth assessment, which was often telephone, but occasionally involved other telehealth means. And we would then link those assessments to running a daily morning clinic at the medical centre of the hospital. We've always operated in the medical centre since the hospital was redeveloped in 2008. Previously, like a lot of drug and alcohol services across the state, were otherwise housed in a little house at the back of the hospital where we were all alone, and gradually got brought into the general hospital functioning. We have a specific area of that medical centre that we generally use, although we don't own it, but we generally use it, and it has various safety mechanisms set in that we were able to organise during the redevelopment, with 2 door rooms and various duresses and the usual security arrangements. And it's also a slightly separate area to the main busiest part of the medical centre where most of the general medical clinics happen, and we share it with pre-op clinic, staff health and physiotherapy, which are generally a more able-bodied section of the medical centre. And some of our rooms are consult rooms and some are interview rooms. And so there's a bit of variety about how we can manage these people in an appropriate setting. And during COVID, so we set up this morning clinic that happened, and obviously we limited our other work and relapse prevention to telehealth options because of the minimising contact. And it was during that process that we formalised our ambulatory withdrawal approach. So what is the Rapid Access Clinic? So our aim is to provide timely access for patients who've decided they need to stop their drug and alcohol use, and where they need withdrawal assistance with stopping, and where they either don't need inpatient level of care, unable to attend, or don't wish to have inpatient care. Referrals are received either by the patient, phone or written, and there's usually a telehealth assessment allocation within a couple of days of that referral. So those telehealth assessments usually happen in the afternoons within our service, and the face-to-face clinic arrangements happen in the mornings. After the assessment, if it's thought outpatient withdrawal is necessary, they're booked into the Rapid Access Clinic, which is a daily clinic, which is a jointly medical and nursing run clinic. And it's usually within a couple of days, or they may be prioritised straight to the Rapid Access Clinic the very next day from a phone call, which, you know, if they're high risk, if they're already in an ED somewhere, pregnant, etc. So if there's some need to see people the very next day, we can usually accommodate that. And as I said before, if people present through ED and withdrawal, then they can be stabilised and then to our clinic the next day. We can advise on what initial treatment might be needed if it's not actually in our hospital with our CL staff, assuming the person doesn't need medical admission. Our hospital has an emergency short stay unit, which most bigger hospitals do tend to have some sort of intermediary care for 24 to 48 hours connected to ED. So it is possible if people present in withdrawal and they can be admitted overnight, reviewed by us the next day, and a plan can be made. And our general approach to withdrawal is following the New South Wales ambulatory withdrawal guidelines, but altering them where necessary. So the Rapid Access Clinic, how do we run it day to day? We have a daily clinical handover review, which is all the staff from 8:30 to 9:30. So we review or present all the patients on the acute, subacute withdrawal list, and specifically all the patients booked in that day. We use that meeting to discuss some of the care needs, some of the potential problems, allocate staff as needed, including if we think we need an extra RN to be assisting with the process if there's a lot of patients, moving some patients to a staff member if we think they're going to need more time, or if we've had an unassessed patient to us booked into that clinic that day, then obviously they're not going to be able to be processed in a sort of 15-minute time frame if none of us have ever seen the patient before. So we have that flexibility to sort of allocate a staff member to do a fuller assessment and then go from there. And we have an Excel spreadsheet, which I'll show you in a minute, which we update every morning except the weekends to keep track of the process and help us with outcome measurements, which Stacey's very kindly helped us with. So that clinic runs 10 a.m. to 12:30 every day, or basically when it finishes. Typically 8 to 16 patients, but sometimes there's more. And so how does it strategically function? So at each review, we assess where the withdrawal's at, explain what needs to be explained about withdrawal, examine what needs to be examined about withdrawal monitoring, and we provide medication until the next review. That comes from the hospital pharmacy in small amounts until the next review, and the pharmacy does not charge our patients. So day 1 to 2, that usually looks, in addition, on day 1 to 2, there may be pathology, there may be other screening, there may be harm minimisation advice, take-home naloxone, etc. Day 2 to 4, we're usually reviewing any results in conjunction with follow-up discussions around the options that's available to them, or look at other options if it seems like we're not being the most useful service at that time. 4 to 7, we're planning the tapering of the withdrawal medications, organising and finalising follow-up, commencing alcohol pharmacotherapy if that's been decided, or linking to opiate agonist treatment if that's been the outcome for opiate presentations. And then...
It's just a question about whether we do that 7 days a week.
Oh, okay. Yes. So it is a 7-day clinic. Yes. So now obviously on a weekend, we don't generally start people on weekends, but we will continue treatment. So through our ED department, our CL nurse for the weekend, we'll have a couple of patients, usually, well, used to be 1 or 2, now it's usually 4 or 5, that they'll see on a weekend morning, and they'll dispense medication through the emergency department, which may be pre-dispensed from our pharmacy, or it may require some MO review in the ED if there's some perceived instability in the withdrawal process. So yeah, that process is 7 days. Stacey can do 2 things. I can't do 2 things at once. I can't do the presentation and read the questions. Yeah. So days 7 to 10, I think we're completing the acute phase, and so generally most patients are finished in that time frame. And then we're linking to make sure we've got letters, referrals, letters to GPs, and follow-up services as required. There may be some moving of those patients to subacute withdrawal, so that there may be some benzodiazepine tapers, or some of the opioid patients, that's a longer process than 7 to 10 days to get through all of that. And so they're not then necessarily booked into that acute clinic ongoing. They'll be allocated specific appointments with specific staff members as we go along. And also it may be booking into the relapse prevention groups or relapse prevention one-on-one with nursing or other staff. So that's a de-identified sort of look at our what we can review each day.
List.
So today's list. So we've got primary drug, secondary drug, if there's more than one. You know, the last use, the date commenced treatment. I can't read what the next one. Today's date, the length of treatment so far, and some notes about the end date, and then the next date is what the next column is. I can't see it because something's covering it up, and some notes that we change as we go along, and then there's some outcome columns as well, which Stacey will talk more about in a minute. And that's automatically linked to the outcome measures.
There was just a comment about the number of benzodiazepine withdrawal patients on there. And the benzodiazepine withdrawal patients, they look like they make up a lot, but you'll notice that in the blue color, there's opioids and benzodiazepines, because these are what we call the subacute. If they're in the blue, they're the patients that we've got for a longer period of time, and we'll talk a little bit about that. Whereas the acute withdrawal, these are the patients that are in mostly the rapid access clinic. Those are mostly alcohol or others. So patients will start off in that yellow color, and then once there's a ticking over treatment plan, then they'll go to the blue one.
And we do have some other color-coded options. If we've got a CL patient that we're monitoring, like a ward patient in green. If we've got a watch and wait patient that's orange because they've disappeared or no one's doing something, or they belong to someone else, but we've been called about them, or they're a frequent presenter, but they're not actually with us. And if we've got our own inpatient in hospital, admitted under drug and alcohol as an inpatient, then that's another color as well. Okay, so this is my last slide before I hand over to Stacey, but I'm happy to answer questions in a second. So why have we set it up this way? Primarily around trying to provide a patient-centered approach where there's an easy access and there's not a huge burden on the patient to get in contact with us, or staff or other services to be able to refer to us. So we end up with hopefully a timely provision of service, or a more timely provision of service. We try to be flexible so we can change times, and whilst we have this morning clinic, there'll be people that work that will be given afternoon times, and we just make sure we've got staff allocated to meet those commitments. We work in a team where the team are very happy to be flexible, and so all the staff will bring up issues in the morning meeting about this person's got this issue. You know, one aspect today was there's a couple with a baby who's just under 1, and they're coming in every day. He's in treatment, she's not, but he can't drive, she's driving. He's taken the week off work, so they're coming in every day, or at least the first few days. And, you know, it's like, well, the clinic's 10 till 12. Just turn up anytime you like, and we'll see you, which, you know, they were quite appreciative of. So there is that constant sort of reviewing of trying to realize that people are real people. They also have lives to manage, and we, in some instances, are asking quite a lot of people to front up several days in a row, and we're often constantly surprised at how people are able to do that. We've also got the capacity, because we can see people, we can change their care, we can escalate care, talk to Lakeview, prioritise admissions, organise direct admission on drug and alcohol or through ED as required. We can assist with triage to mental health if there's some mental health issues that have gone awry during the process. And we may, as I mentioned, we may commence or link to opiate treatment programs. We're able to provide a pathway for an ED presentation. So primarily, you know, ED's got 4 hours time limits and all of those things for their performance indicators. And this hospital works quite proactively with us, that they'll call us because they know that if they get a plan in place for drug and alcohol, then that means the whole thing's going to be sorted out much more quickly, even if we're not the primary problem for the patient, or the primary reason for presenting. And we've got pathways for continuing withdrawal from inpatients and other settings. So that's not just our hospital. If we've got CL in John Hunter and Maitland, we're progressing with CL in Taree and Manning and trying to provide links in those areas for continuing care. So that's also good. We've got the ability to plan tapers of medications on discharge. If people discharge against advice, we're able to offer a pathway if it's appropriate. For instance, if someone's at Lakeview and they need to leave early, whether that's unplanned or whether it's we prefer you to stay longer, but there's child issues or grandma's visiting or whatever the reason might be, we have the option of being able to continue care if the patients can present to us. And as I said, we can take referrals from other EDs. We try to foster good communication and cooperation within the multidisciplinary team, and we're fortunate that not many of our staff are new. I think all the nursing staff have worked in drug and alcohol for 10 years or more, some 20 years, some 30 years, 1 or 2 30 years. The OT and social workers are newer to drug and alcohol, but we're still approaching 5 years, 3 to 5 years for those staff. And we take seriously the training opportunities that the rotations come through, whether it be the basic position training, the JMO rotations, or our being part of the advanced trainee position for Hunter New England. So they rotate through our service as part of their training. So that's why we do it. So before I move on to Stacey, questions about any of that?
Craig, can you hear me? Dan
Yes,
Wilson here in Barnsley, Alice Springs. Thanks for such a clear description of your services. Just a question about pharmacy. I think you mentioned that you've got the capacity to provide medications to cover that withdrawal period through the hospital for free for some or all patients.
Yes. So when I say free, it goes on our budget, but the medications we use are typically not very expensive.
Yeah.
Using a bit of diazepam and antiemetics and whatever else we use, buprenorphine. So that doesn't cost a lot to our budget, but the pharmacy will dispense it in little packs in however we've written it up. We have the best head pharmacist ever, and the pharmacists love our patients. They really they invest their time as much as we do in trying to look after the patients. And often the patients will come back and go, those pharmacy staff, they're just so lovely, which is not necessarily the case you get everywhere. For instance, we don't have a very good working relationship with John Hunter Pharmacy for a whole variety of reasons. And despite best efforts of trying to fix that, ultimately you rely a lot on the attitudes of the pharmacy.
Yeah. I think that capacity to support patients, through that short period of withdrawal with medication that they're not having to go out of pocket for to a community pharmacy, worry about dispensing quantities and cost of dispensing quantities. It's a really lovely arrangement, and similar to here in Alice Springs. So it's a good model.
We'll see one of the examples a bit later too. With some of the longer term prescribing, they'll move to a community pharmacy, whether that be opiate treatment or whether it be the benzodiazepine tapering. Once we've stabilised, and particularly if it's going to be over a longish period rather than a shortish period, they'll go to a community pharmacy and be on stage supply, and hence then they're paying more. But yeah, thanks for that. Any other questions? All righty. So I'll move on to...
Excellent. Thank you.
Stacey.
So I'm going to talk a little bit about the types of patients that we see and the kinds of numbers of patients that we see, just to give through some worked examples. Having a look back at our numbers from 2022, 2023, 2024, and our year-to-date numbers for 2025, we can see that we continue to increase the number of individual withdrawal episodes that we treat each week, each month. So in 2022, that was around 48 patients a month, and for 2025, that's about 64 patients a month. There is a great amount of variability in how long we treat people because it's really substance and patient dependent. Fairly stable across the years that we've looked at since the rapid access clinic model. Most patients who have an initial assessment, which at the moment is now usually done by phone, and then they elect to get booked into withdrawal clinic. So we call that an assessed. So once you're booked in to the withdrawal clinic, about 80% of those patients will go on to attend that first appointment and be given withdrawal treatment to commence. Obviously, there are a number of patients who might be interested at the time of the assessment, but then not go on to start treatment. And that's why our rapid access clinic model is so important, because motivations and ability to change can fluctuate quite quickly. And we found over time that the longer the wait list, I'll explain that, thank you. We found that the longer the wait for people to come to treatment, the more people don't come. So if we, at various times when our waiting list has extended out, we find that people, their motivation and their readiness to change and their ability to devote the time and energy to do that changes. So we do the best we can to see people as quickly as we can. And sometimes that means that the whole team needs to be flexible to see an extra 5 patients in the clinic that day. The DNS means did not start. So about 15 to 20% of patients or just over don't attend that first appointment. And then when we look at whether they completed treatment successfully or did not complete treatment successfully, that's a clinical decision that we make as a team based on whether we think the patient's withdrawal symptoms have been adequately managed to completion, and medication has usually been tapered or stopped. So that's the timeline that Craig was sort of talking about before. And that's very individual, and it's obviously very substance dependent. So if we define a successful completion as either having completed withdrawal clinic or being transferred onto another service or commencing opiate treatment, across the board, that is around about 70 to 80% of patients who start treatment will successfully complete treatment. And that's usually judged at the end of the withdrawal. A number of patients, about 20 to 30%, won't actually complete the withdrawal. So they'll have relapsed to use or disengaged from the treatment process. Many of those patients will come back another time.
So yeah, Y is yes, YTF is yes transfer, meaning the person was doing well with us, but we transferred them before the end of completion. And OAT is they've been transferred to OAT. That's been established. And no is they didn't complete, or a no transfer is they weren't doing well with us. They were still using and they were transferred to another service.
So a yes transfer is commonly the person has gone to a private mental health admission, or they might have gone to their GP. Or a no transfer might be they have gone to Lakeview because they were struggling on treatment and weren't successful in the outpatient model. And we've arranged for a short notice admission to Lakeview. Or sometimes they'll have become unwell in the process and been admitted somewhere, but that's less common. Often the transfers are planned transfers. Or sometimes they might have gone on to a private, like some private treatment elsewhere. From our spreadsheet, we can generate a little dashboard. This slide is a really busy slide, so don't focus too much on it. But we are constantly trying to have a look at the types of patients we see and where we're sitting as far as our outcome measures, which is predominantly completion or not completion. But it's useful for us to have a bit of a look at the trends and difficulties with withdrawal management. So we'll see later on that the proportion of people presenting with various substances is not static over the years, for example, with GHB or other substances. So alcohol withdrawal management is the most common substance that we treat. The patient assessment, again, happens by phone. Many patients will self-refer, although it's not uncommon to get referrals from other medical specialties or GPs about concerns for alcohol use. And of course, we do get a lot of people coming from the emergency department. Most patients are actually suitable for ambulatory alcohol withdrawal management. In years gone by, back, before COVID, we used to say everything's before COVID. Many patients with a history of previous alcohol withdrawal seizures we would say that those patients were absolutely required to have inpatient treatment. But we now treat a lot of patients with a previous history of withdrawal seizures in the outpatient setting with daily reviews. So much of it depends on the patient's capacity to attend an appointment and the types of supports they've got around them and their own confidence in managing their withdrawal. Oftentimes the patients that are not suitable for outpatient alcohol withdrawal management are those with such chaotic lives that they really need that period of stability of their other substance use so that they can kind of deal with the withdrawal symptoms and have diazepam safely administered. We do treat patients with advanced liver disease in the outpatient setting using oxazepam if it's appropriate. And again, we do that with frequent clinical monitoring and drug selection. The first appointment will usually involve, does take a little bit longer, where we assess the patient's current state of their withdrawal according to when their last drink was. A breathalyzer is almost always performed, and we usually send the patient for some pathology. Some medication is prescribed, and then they get reviewed daily or second daily. The post-withdrawal follow-up planning actually begins at the assessment appointment, and that's really important, and it continues on all the way through. One of the important roles of our multidisciplinary, of our handover meeting, where we all sit together, is that a different nurse might be rostered to the withdrawal clinic, and many clinicians will be involved in that patient's care during their journey. But because we have all talked about that patient all together, then the patient doesn't have to repeat their story. We have a common goal for the patient and an understanding about where the patient's up to in their withdrawal course, but also with their plan and the types of risks and detractors that they have.
Having said that, we try to have the withdrawal nurse consecutively the same person for a few days, and then it changes. So they rotate, so that one person might be covering ED, one nurse might be doing the withdrawal clinic, one person's doing wards, and they may be consistent for several days, and then they'll change.
So I'll give it, there were lots and lots of patients to choose from. So all of the examples are patients that presented yesterday. So that way I didn't have to pick from all the patients. We just chose some people that we saw yesterday. So the first is a 50-year-old lady who initially had a presentation to the emergency department in March. She presented after an unwitnessed fall at home whilst intoxicated, and she had a minor head injury. During that ED presentation, she was noted to have some mild transaminase elevation, and she was given some harm reduction advice in the emergency department. It was identified that she had an alcohol use disorder, and she was given information about our service and how to access ambulatory withdrawal. She had a phone assessment completed the next week. So she'd called up in that intervening time, and a phone assessment was arranged. During that phone assessment, she revealed that she was drinking 120 to 180 grams of alcohol a day. She has a previous history of opioid use disorder on opiate agonist treatment in 2016, but hasn't used opiates since then. She lives alone and she works full time, and she was keen to stop drinking, motivated by her emergency department presentation and the discussion around her liver enzymes. The post-withdrawal plan was discussed at that appointment, and some pharmacotherapy information was briefly discussed, and the plan was made for her to do the group program, the Women's Relapse Prevention Group. And she was booked for the withdrawal clinic again, trying to fit in around her work. So that her appointment wasn't for 10 days, but again, that was really to try and fit in with her work schedule. At that clinic appointment on the 14th, she reported as her last drink being the night before, and her breathalyzer was 0. She had mild symptoms of withdrawal, and the plan was made to give her a fairly standard regimen of diazepam with 8 tablets or 40 milligrams supplied for the next 24 hours. There was some pathology requested, and she was given safety advice regarding driving and the triggers for representation. So we always tell people, if you take this treatment and it's not working, you can come back to the emergency department, and here's what you can expect. We say, you can tell them that you're having alcohol withdrawal treatment, and here's what you can expect to happen. Thankfully, few patients need to avail themselves, but it's important that they know that during business hours, we're always available by phone, and after hours, there is support available. She was seen the next day and she reported that she had had 2 beers the day before, but her breathalyzer was 0 and she was given another 8 tablets of diazepam. Her obs were okay, and she was complaining of some nausea, so she was given some metoclopramide, again, at no cost. When she was followed up the following day, she reported some improvement in withdrawal symptoms, but ongoing nausea. She was given a slightly lower dose of diazepam and some ondansetron. And she was seen the following day, again reporting no alcohol. Her nausea was improving. She had a mild tremor, and she was planned to give a tapering regimen of diazepam over the next 3 to 4 days. And pharmacotherapy options were again rediscussed, and she was given a week's supply of naltrexone because she elected to start naltrexone at that time. So it's not uncommon that we might give people a short supply of alcohol relapse prevention pharmacotherapy in the first instance. This is 2 reasons. Firstly, the medical officer who is in the rapid access clinic is generally a junior doctor. And so while we decide together what pharmacotherapy options might be appropriate, and our very experienced nursing staff go through that with the patient, they don't have at that very second the capacity to provide a PBS script. So that's something that you need a prescriber number for. So some patients, like this one, will have had multiple episodes of that pharmacotherapy option discussed, but be given a short supply of pharmacotherapy in the lead up to an appointment with either Craig or myself or one of our advanced trainees. She came back the next week. She hadn't started the naltrexone yet, and she'd had a couple of episodes of drinking. She was seen, the pharmacotherapy options were again rediscussed, and she was seen by one of our staff specialists, and she again elected to commence naltrexone, and she was booked in for the relapse prevention group the next week, which she attended. She followed up the following week with a staff specialist. By now it's the 7th of May, and she'd had a relapse to drinking since the last review. At that stage, she reported drinking 30 to 40 grams a day and was keen to moving towards abstinence, and was asking about disulfiram, but she wasn't ready at that stage or didn't feel that she needed further ambulatory withdrawal management. And she was offered one-to-one support. Our occupational therapist does like some preparing for change types of interventions for people who are heading towards making a change but aren't quite ready for withdrawal management for whatever reason.
Or it's started and they've become more ambivalent with the process.
She wasn't seen again for a little while, almost 2 weeks later. Again, this was all trying to fit around her kind of chaotic work situation. She doesn't have the capacity for a lot of flexibility there. She was again seen by a staff specialist, and she reported struggling to maintain abstinence. And she was now back up almost to where she was before, about that 100 to 120 grams a day. And a plan was made to commence alcohol withdrawal treatment the following day. She was seen the next day. Her breathalyzer was 0, and she had some mild symptoms, and was given a small amount of diazepam, but she wasn't prepared to come every day until the following week, again, just trying to fit in around her work. This lady, obviously, she's a single woman who's struggling to pay rent, and she's got a casual job, so there's a lot of trying to fit in around where she is up to. She came back on the 26th. She hadn't yet started the withdrawal treatment and had drank the previous night. We rediscussed the options. So this is not an uncommon kind of story for people. They might drift in and out of withdrawal treatment. And at each point, we take that opportunity to rediscuss whether this is really the right approach. This patient would have been offered inpatient admission. We talked about things that were working for her and things that weren't working for her. We talked about increasing the intensity of your review or reducing the intensity. So she was given lots of options. She was seen the next day again by the same staff specialist. She had not had any alcohol, and we rediscussed the pharmacotherapy options, and she felt really strongly about trying disulfiram. She had multiple episodes of multiple opportunities to discuss the various options. She was then seen the following day and then commenced on disulfiram. Again, normally we would try and wait till the end of the withdrawal to start disulfiram, but in some highly motivated, keen patients who are clear that that's what they want, we do start disulfiram sort of in that third and fourth day. She was seen a few weeks, the next week, doing well on disulfiram, and described feeling liberated. She described a great sense of relief at being in a position where she can't drink anymore. She followed up with the alcohol relapse prevention group, and she was seen yesterday. So she's now heading on a month on disulfiram treatment. She's abstinent from alcohol. She's engaging in her liver enzyme monitoring and still attending one of our groups when it fits in around her workplace, and she feels great. So with the disulfiram, whilst the mental health and substance use service has a supported disulfiram group where patients will go and receive a 1-week supply of disulfiram at subsidized, the patients that we see manage their own disulfiram. This patient was prescribed usually we give someone a week or 2 weeks supply of disulfiram from our pharmacy, again at no cost, until they are have attended their first review, and then they're provided with a prescription for disulfiram, and that costs in our area between about $90 is about the cheapest that you can get the disulfiram, and there are some pharmacies which don't stock that, but patients tend to, that we don't have supervised disulfiram, if that's your question. So across the years, about 2/3 of our patient population is made up of alcohol. So even though when we look at that withdrawal list, there seems to be a lot of benzodiazepines, that's because they tend to hang around the list for longer. Consistently across the years, most patients who come to our service for withdrawal management are there with alcohol as the primary substance of concern. Most patients who have an assessment will start treatment, and once they've started treatment, about 80% complete. And that completion, the treatment duration for patients in 2025 who are receiving alcohol withdrawal treatment for our service is about 8 days of withdrawal management once treatment is commenced. So what that might look like Craig said, is we've got the first couple of days with regular reviews and then less frequent reviews towards the end of their treatment, and then planning for follow-on. Some patients, like this one, will have a stilted course where their treatment duration will be longer than the 8 days because they haven't completed yet. They're still sort of drinking on and off, or they're struggling with withdrawal symptoms. So benzodiazepine withdrawal treatment, as you saw, we do have a number of patients on our withdrawal list who are seeking treatment for benzodiazepine withdrawals. They kind of broadly come in 2 categories. The first one is patients who are prescribed benzodiazepines, often for many decades, initially treated for anxiety or some kind of adjustment disorder, and they may have had a GP or a psychiatrist who's been supporting their prescription for 30, 40, 50 years. But then at some stage, either a decision is made that they need to stop that because of the mounting risks of their benzodiazepine treatment, or, as often happens, unfortunately, is they outlast their prescribers, and they find it very difficult to get a new benzodiazepine prescriber. Our public psychiatry service is loath to support benzodiazepine prescription in the longer term, which is understandable, but many of these patients had psychiatrists who were supporting them for some decades, but now they're unable to sustain that for whatever reason. So the other group of patients that we see are patients who are using illicitly obtained benzodiazepines. Often that's street alprazolam, and those patients commonly have comorbid substance use disorder of a variety of sorts. And those patients will tend to present in crisis, or they might come on the back of an admission for withdrawal, or because their benzodiazepine use is getting in the way, they might have legal complications or assaults or something like that. And those two patient groups do tend to have different treatment courses. For patients who are referred from a doctor, usually the patients who are prescribed benzodiazepines, their first appointment will almost always be with a staff specialist, where we can go over the prescription history and talk about getting the patient on board. Those patients often come with different motivations than the patients who are self-presenting. Whereas patients who are self-identifying as benzodiazepine dependent, wanting to change, they will tend to be booked into the rapid access clinic. The progress is the same with a stabilization phase with more frequent reviews, followed by a longer phase with less frequent reviews according to what the patient needs. So this patient that we're talking about is a 44-year-old man who was advised by his private opiate treatment prescriber to seek treatment with us for outpatient benzodiazepine withdrawal. He's on methadone 160 milligrams a day, but disclosed a 3-year history of illicit alprazolam use. And so he had a phone assessment and was booked into the rapid access clinic the next week. Oftentimes, there's quite a lot of flexibility depending on where the patient's up to with when they want to come in. On the first day that he presented, he had some features of withdrawal, and is described in the notes as being fidgety, but not tachycardic, and he used a little bit of alprazolam that morning. Obviously, with that methadone dose, we do want to be able to see people, but given that he already had some withdrawal, we gave him 40 milligrams of diazepam for the next 24 hours and reviewed him.
Might just say, we've seen the 2-dose sulfur
yes,
question
we'll
comments.
Mention those.
we'll answer them in due course.
Yep. For the he was seen the next day. He looked well. A urine drug screen was obtained at that time, and obviously the history was revisited and the harm reduction advice was reinforced. He was offered bloodborne virus testing and Nixoid. Interestingly, the fast urine results take about 3 weeks to get back, and he didn't have any alprazolam metabolites or novel benzodiazepines that we could see, but he did clearly present in withdrawal. Obviously the diazepam that he was given the day before presented, but we are seeing there's a couple of patients who report alprazolam use who clearly look benzodiazepine dependent and come with withdrawal who don't have alprazolam or similar metabolites in their urine. So I suspect that we're just not seeing all of the possible 157 million different types of benzos that might be present in the illicit alprazolam supply. The next day he was feeling okay, still on the 40 milligrams a day of diazepam, and so we tend to stabilize people on a dose similar to that over a few days, because obviously it takes a few days to understand what trajectory benzodiazepine withdrawal is taking. He was reviewed daily, and then the plan was made to reduce the dose. He was then reviewed weekly with a staged supply of benzodiazepines. He gets his methadone supplied in a take-safe device, which is like a timed methadone device, which is locked from his private pharmacy. And so we actually spoke to the supplying pharmacy, and his benzodiazepines are dispensed daily with his methadone in that take-safe device. And we do that by working with his private prescriber and the private provider of his opiate treatment. Yesterday, he has managed a very significant reduction. He's now on 5 milligrams 3 times a day, and the plan was to continue as we are at reducing 2.5 to 5 milligrams every fortnight as tolerated. Even though it looks like we see a lot of benzodiazepine withdrawal patients on our withdrawal list, they only make up about 5 to 10% of the patients that we see. Again, most people who have a treatment assessment start, and once we start treatment, the completion rate is about 60 to 70%. That's fairly significant still, given the length of time that we see people for. Benzodiazepines is one of our longer substances that we see people for, and in 2025, the average duration of completed withdrawal is 58 days. Currently, the longest is 625 days. She still doesn't like me. I try to be really charming, but we're getting there. But of course, Craig's had got someone out to 5 years.
I've got the record. 5 years to the day almost.
But he's well now.
He's very well.
He's well now.
2 years after a 20-year history of alprazolam use, initially prescribed for anxiety disorder with a private psychiatrist who then retired, and he sourced from Street and his GP for many, many years. He's now 2 years without, and miraculously, his anxiety is far better than what it ever has over 20 years.
And it sounds like a long time, 625 days, 5 years. That sounds like a really long time. But for these patients, we are often talking about many decades of alprazolam prescription. The patient who I'm seeing at the moment with 625 days was on alprazolam for 40 years, since her early 20s. So sounds like a long time, and it certainly is a big investment. But the difference that it makes for people when they're not taking 3 milligrams or 6 milligrams of alprazolam a day is quite significant.
And just the reason we end up being the prescriber in a lot of these cases is because initially, the more straightforward ones we just do through the GP and just offer advice, specialist advice intermittently, and the GP would do the prescribing. And that still occurs, but often we've got these people where the GPs don't wish to prescribe, or the GPs have been attempting to make changes and they haven't been able to maintain that, or the patient's lost their GP, or for all those reasons that we end up being the prescriber long term for some of the more complicated people.
And it's actually really valuable because it means that conflict around the benzodiazepines or the prescribed opiates, they can have that conflict with us. And it still leaves them to have that preserved relationship with their GP, who can then look after their multiple other complexities. So that patient who I've been looking after for 625 days, it feels like every bit as long as that. But she accepts that that's the role that we have here, is to support her to gradually reduce. And yes, we almost always use diazepam.
Yeah, so there may be occasions. So obviously any other long-acting drug could be used. And so if someone's on clonazepam, theoretically you could do that, but it's more restricted. It's difficult to prescribe. You have to have an authority. It's only PBS for seizure disorders. So there's cost factors and breaking up tablet factors and various things. So we almost always diazepam. Occasionally, if someone's just on an octane dose of a medication, so occasionally a Z drug or occasionally like a temazepam, we may just decrease that tablet if it's a modest dose. But generally, it would be switching to diazepam. Shall we answer the disulfiram questions? I think Steve Kelly had a question about compounding being cheaper. And as we probably all know, disulfiram goes in and out of supply, or the Antabuse brand that's registered in this country goes in and out of supply over the last 15 years. And so multiple pharmacies have developed the ability to compound disulfiram, which is very valuable for the patients. In Newcastle, it's not that much cheaper. It's typically still $80, $90, $80, $90, $100 for a month's supply compounded. So I note Steve mentioned it might be cheaper. And there's this another note about the Pharmacy Guild suggests compounding shouldn't happen. I'd have to say I don't know the legalities of that within the pharmacy realm, unless someone else does. But it's been a valuable service for people who have done well on disulfiram when it's not available to have that option.
And most of the patients who we prescribe are actually getting a compounded product. Ambulatory opioid withdrawal treatment, that would be good.
Yeah, thanks, Steve.
Yeah, we might get them.
We'll send them all down.
We might get a post. Ambulatory opioid withdrawal treatment. So opioid withdrawal treatment is something that patients come asking us for. So again, we've got two categories of patients. One is the group of patients who have chronic pain and long-term opioid prescription, who have for some reason lost their prescriber or had an interruption in supply of their prescription, or for whom their prescribing relationship has become so complex that they need assistance, but may or may not have an opioid use disorder per se, and may or may not be best suited to an opioid agonist treatment. Other patients come with illicitly obtained pharmaceutical opioids or heroin use, and for whatever reason, they don't want opiate agonist treatment. So the patients that we see come specifically requesting not opioid agonist treatment, although some of them do end up on opioid agonist treatment. So this lady briefly presented at the end of May, 41 years old, seeking opioid withdrawal treatment for heroin use on a background of previous opioid dependence and previous treatment experiences with methadone and buprenorphine. She had done well for many years on treatment and off treatment, but had relapsed fairly recently, and she was pretty clear that she didn't want treatment. She could actually access a private prescriber who'd prescribed from her before, but she elected to come to our service even though she had already booked an appointment with her private prescriber. She was clear that she just didn't want to be on opiate agonist treatment, and she felt that her relapse was sufficiently brief that she'd be able to manage. When she came on the 27th of May, we revisited the history and made clear that we understood where she was up to and what the risks were. And again, talked about the reasons why or why not opiate agonist treatment might be beneficial or not. Obviously, we always talk about the gold standard of opioid use disorder of moderate to severe severity being opioid agonist treatment, but it's not always in line with patients' goals. When she had some mild withdrawal, she was uncomfortable, restless, with bowel sounds audible across the room, and some mid-sized pupils, but she still sort of felt like that's what she was up to. She was offered some sublingual buprenorphine, but declined that because she lives about a 45-minute drive, and she was seeking injectable buprenorphine as withdrawal treatment. She was given an 8 milligram depot and some symptomatic treatment, including clonidine, diazepam, buscopan, and metoclopramide, and she was booked to come the next day she was offered an appointment the next day, which she declined. She didn't attend her appointment on the 29th. We tried to assertively follow her up, but she did come the next week, saying that she felt well, but she was still having some difficulty, and she was requesting some more symptomatic treatment, including clonidine and diazepam, which she was provided with. She didn't want any more buprenorphine at that time. The next week, she obviously was offered other appointments, which she declined. She came the next week after having relapsed to heroin use and had used a couple of times since then. She still wasn't sure she wanted opiate agonist treatment, but she did want some more Buvidal, so she was given 16 milligrams of Buvidal. And again, we discussed what treatment she wanted. Is outpatient still the best? What about inpatient? What about rehab? What about opiate agonist treatment? Here are all the risks. And she was booked again on the 19th, and she didn't attend, but she did come yesterday. And when she came yesterday, we'd rediscussed those options, and she'd made a decision that she wanted to stay on opiate agonist treatment. She has a preference for going back to her private prescriber, so we gave her another weekly dose of Buvidal with an appointment to come next week with a view to moving on to monthly and hopefully transitioning her to her private prescriber after that. We rediscussed harm reduction. We offered, I had a conversation about contraception, and we prescribed her some nicotine replacement therapy. Opioid withdrawal treatment only makes up a very small percentage of the patients that we see, between 5 and 7%. But for patients who come, they actually have a high completion rate, above 85%. That tends to be because the very patients that they're coming are very motivated that they specifically are requesting opioid withdrawal treatment. Opioid agonist treatment is commenced in about 30 to 50% of patients who initially say they want opioid withdrawal treatment. And we see that as successful completion. There's variable treatment duration. Again, the current record holder goes to Dr. Sadler with 2,574 days. Sadly, I've been around long enough to be there on that first day.
Yeah, I hold Dr. Weedon responsible because
I went on maternity leave 3 times in that time. Twice.
This gentleman presented acutely in moderately severe opioid withdrawal, not through ED, to our clinic after his normal GP, who was prescribing up to 400 milligrams of morphine daily for an extended period, went on medical leave and didn't return. And the appointed GP to assist took one look and went, "I'm not prescribing you anything," and sent him to us. so he was in acute withdrawal, and we normally would not take on the authority for prescription opioids in anybody. In fact, I think this is the only person we've done it in for a very long time, apart from buprenorphine and methadone. Multiple pain issues which needed to be sort of looked at and sorted in terms of chronic pancreatitis from previous alcohol use, but abstinent from alcohol for years. Peripheral vascular disease, which was quite progressive, and he's since had a below knee amputation on one leg. Peripheral neuropathy secondary to secondary diabetes from his pancreatitis, which requires insulin, and neuropathic pain, also a background of chronic back pain after an acute injury when he was younger. So there's quite a number of things. He's still got acute on chronic pain with his peripheral vascular disease and his back pain and his chronic pancreatitis and his neuropathic pain. So we had to move him from acute withdrawal to a different path. So anyway, we did reduce his MS content, his morphine, over an extended period, and it's now ceased. And he has a small amount of endone, which was initially started during an inpatient admission with acute vascular problems. And so he does currently utilize 5 to 10 milligrams of endone a day. So an unusual patient to look after. And
but again, even though we continue the opioids, he's not totally done. I've looked after him through a couple of when he keeps on getting bits of his feet and leg chopped off. And even if we think about what the difference in outcome might have been if he was still on 200, 400 milligrams of morphine a day compared to almost none, his post-operative course has been really easy. He's not come out on more opioids than he went in on any of those complicated admissions, despite having amputations and things. Very, very briefly, we do see patients for methamphetamine and cannabis withdrawal. They make up a minority of the patients that we look after. More commonly, they are a co-substance use. So patients will have cannabis use disorder or stimulant use disorder along with another substance use disorder. And that's why the primary substance of concern is less. We do offer diazepam medication or various other symptomatic treatments as required for those patients, and the completion rate is variable, and it really does depend on the other comorbidities. And we do a small amount of ambulatory GHB withdrawal. It's probably a whole topic in itself, so we won't spend too much time talking about it, but it's just to say, I guess, that GHB withdrawal can be challenging both as an inpatient and an outpatient, but commonly we see people who either are in withdrawal or have just come on the back of an overdose and are highly motivated to not use. And so we initially had no choice but to start withdrawal treatment, but over the years we've found that many patients are actually able to manage GHB withdrawal safely in the community with a combination of benzodiazepines, usually diazepam and baclofen. Oftentimes that might come on the back of an inpatient stay, although we do see people on day one as well. And the number of patients that we treat has been going up year on year, with 13 in 2025 to date, and 16 last year and the year before, and 2 just the year before that. So it is actually a reasonable number of patients, and they tend to need a long period of treatment with frequent reviews.
Okay, so questions, or were there questions that propped up, Josh, that we didn't address?
Hi, can you hear me okay?
Yes.
Yeah.
Great. Look, I think you managed to get to all of the questions as you went. There's some very interesting discussion about some sort of arcane pharmaceutical knowledge, which I'm learning with the disulfiram question. But we've got a few questions popping in now, so I might let you read those and get to them.
So we can comment on, we'll try and look at the chat ourselves now, but there was that question around protocol for GHB withdrawal. So basically, adapted from the state guidelines, but the combination of using diazepam and baclofen. And again, it's that daily supply of medication, so we can constantly re-review and make sure that we're not overdoing it or underdoing it. We tend to treat the first 24 hours in people that we're pretty sure of the GHB history as with equivalent diazepam as we would with a higher risk alcohol withdrawal. So making sure there's an adequate loading of doses. We may sometimes even give doses and keep them around and review them for the first couple of doses. That's the sort of general approach, which is protocolized and individualized, if you like. The baclofen tends to be a standard dosing regime of 10 TDS, sometimes 20 TDS, and that's usually just kept static the first week whilst we deal with the Valium, taper the Valium, so that we're not using that for too long, and then taper the baclofen in week 2.
And those patients are usually seen daily with medication supplied day by day.
Yeah. Because they're a high risk group, plus they're also a slightly more unreliable group, and they're often continue their methamphetamine use. So it becomes a risk management process as well.
And difficult with the methamphetamines because they come in tachycardic, and you're not sure whether this is the GHB withdrawal or the methamphetamine that they've just used before they came. So it is challenging, but patients have a strong preference. Patients in particular with GHB use disorder have a strong preference for outpatient management. And I assume that's because of anxiety around symptoms and the speed at which we can get on top of symptoms in the inpatient setting, despite our best efforts.
And so, yeah, some of them do transfer to inpatient care, Dan. Richard, yes. Yes, some of it is fortuitous how this service has developed, but not all of it, because Aidan Foy had a broad view, and as this area's drug and alcohol services became developed and melded over time, and more services came on board, because at the start there was this unit at Royal Newcastle and opiate treatment when it was set up in the late 70s, early 80s. And that's all there was. Then there was psychiatry did inpatient withdrawal in the psychiatry hospital. Richmond report, deinstitutionalise care, plus move drug and alcohol out of psychiatry inpatient settings. And they set up a non-medical withdrawal unit, which also happened elsewhere in the state, which basically is unmanageable for anything except withdrawal that doesn't need any treatment. And then that evolved over time to creating a medical unit along with the development of the community services. And so fortuitously, all of that led to all of the services communicating about how they would be aligned and who would do what, and to try and have a process of inter-referral. So it works reasonably well with withdrawal and CL services. It varies with some of the other community services that are challenged in managing the number of patients they see in a practical way.
Advice that we have, I guess, is really that staff need to be flexible and be able to work together to deal with the demands, because the ability to see people quickly and responsively is really important. We also try and keep the assessment process and the barriers to service to a minimum, so that patients can self-refer without the need of seeing someone else. GPs have an easy access referral pathway to patients, and that other medical specialties and ED can get their patients seen quickly without the need for burdensome paperwork. Obviously, we're going to do our own assessment anyway, and so trying to keep the referral barriers to a minimum is really important. Of course, there's always a worry that we're going to become overrun, and in some days we have more than 20 patients, and we've running, we've each got 8 or 10 patients to see in the clinic, and there are some days it does get busy, but it tends to be self-leveling, because the longer the wait, the less patients come. And ultimately these patients all exist anyway. They're either going to come to the emergency department with a complication, or they're going to be turning up after a fall, or they're going to see you eventually. So it doesn't make sense to artificially limit the number of patients that you see. And do you think that there's an unmet need? There's definitely an unmet need. I feel like we could probably double our access clinic. We could see twice as many patients And I think, there would still be more patients to see. There's definitely an unmet need for follow-on care, like counselling services, both in the public service and the private sector. So there's lots of unmet need.
And I'd probably say, connected to that question with opiate treatment, they went through a similar process, the opiate treatment services for Hunter New England during COVID, and they really redid how they approached people. I won't go into the detail, and obviously it was the same time that Buvidal came on board, and we were already familiar with Buvidal because we've been involved with some of the trials, and so we're able to increase the numbers and the use of depot buprenorphine quite substantially. And so within a few years, the numbers on OTP treatment in Hunter New England have doubled from 700 or 800 to 1,500-1,600. So there's a lot of patients being managed by the opiate treatment services. And they approached it in a similar way, in that there used to be this list and there used to be this waiting time, and they just removed it. And they just would take the referral, book a nursing assessment, determine then where the patient needed to go within the opiate treatment service, or did they need to go somewhere else. And that's led to the access to opiate treatment in Hunter New England being much improved from 7 or 8 years ago.
And Chris, your question about do we have any alcohol withdrawal seizures? Yes, we probably do. There are some. Famously, we have had a couple of people have a seizure in the in the check-in, like as they're checking in. But the reality of alcohol withdrawal seizures is most of them happen really early on. And so many of those patients have had a seizure, and that's actually why they've come to the emergency department, and then we pick them up in the follow-on. There have been patients over the years, not that many, who've had seizures on our like after the day one treatment. But for patients who have a very high level of dependence and neuroadaptation, we're often starting withdrawal treatment even before their breathalyzer is 0. So the flexibility of being able to come in and have an assessment, and sometimes we might see someone in the morning, they might have a mild level of intoxication, and we don't feel like it's right for them to start treatment right this second, but we'll offer them a reassessment in the afternoon and make a decision then about whether or not to start treatment. They're not advised what their advice they're given is, it's really important that you don't come to your assessment intoxicated. They're not given specific advice about when they need to stop drinking, because we just take what we see on the day. We've had a number of patients rock up to the clinic with BALs of 0.3 or 0.4, and obviously we don't give those people benzodiazepines on the day, but we try and work with them around finding an appropriate time to start withdrawal treatment. As far as long-term outcomes are concerned, that's actually a little bit more vexed. It's a huge number of patients to try and work that out. And actually what we're focusing on at the moment is trying to get our on-treatment data set. So each year we continue to make improvements with the information that we see, and we manage that dashboard and how we talk about it. And so that's where our energy is at the moment.
The nursing staff are crucial. We have excellent nursing staff, which we try to tell them every day how excellent they are. Mm-hmm. Loading, yeah. So we sometimes do the standardized loading of 10 to 20 milligrams, 3 doses, and sometimes that happens in the clinic, and we're just getting people to hang around so we can assess the difference between first and second doses. It's a medical center, so there are rooms with beds. There is a monitoring area in the medical center that if we really need to use someone and have them lie in a bed and be monitored for several hours, we have the capacity to do it, even though they don't always think it's their job. It's their job to monitor the bleeding gastro patient or the hematologically compromised patient, but not the drug and alcohol patient. But we've worked with that over the years, and we do it so rarely that it's usually manageable, or it ends up being one of our staff that just spends a few hours down in the clinic with someone. So yeah, there are definitely high-risk patients that we will take on, and part of that is because they can't get a bed, or we're starting from the high level of intoxication and monitoring them in that process and then loading them. And as good as our relationship is with Lakeview about prioritizing, it still can be days, weeks, depending on what's happening before you can get someone in. And so, just leaving someone to keep drinking that's already at risk is who wants to do something, then you've got to weigh up the pros and cons and risks of that.
And the question about waiting for pathology, we almost never wait for pathology to come back before starting withdrawal. Usually they'll get pathology on the way out the door, because the pathology is opposite the pharmacy. So they'll usually be seen in the clinic. A general assessment of their physical condition and history is made, and then they get pathology after they pick up their Valium.
If we've got known history around their liver disease, we may make the call of using oxazepam, but sometimes in my clinical experience, using the first few doses of diazepam and then changing is not going to compromise their liver function, and is better to have a longer acting benzodiazepine on board in those first 24 hours and then switch. And obviously there's clinical assessment that happens, and if we think the person is quite unwell, then we're usually organising a different level of care.
Sometimes even marching them down to the emergency department. We have people who might present clearly unwell, or when they come with a BL of 0.4 and we just can't possibly bring ourselves to let them go. We might march them around to the emergency department, or something like that. So we're not beyond leading them to the emergency department and sitting with them until they get triaged. We've done that more than once.
Ruins everybody's day.
It takes a long time.
The patient's day, our day, ED's day, everybody's day.
But then those patients, they usually spend the night in ED, get treatment started, get some bloods and some thiamine, and then we see them the next day, and then they go home.
So just on the thiamine note, we do have the potential to give parenteral thiamine in terms of intramuscular in the outpatient setting. And obviously, if we've got a super high-risk person, they'll go to ED. But there are patients that will give a series of intramuscular injections of thiamine over the first few days.
And B12 for patients with nitrous oxide use. So patients will come in and get B12 injections every 3 days, 3 times a week for a couple of weeks if they've got neuropathy from nitrous oxide use.
Have you missed any questions, Josh?
Look, I'm looking through. I think that's it for the questions online. Oh, just as I said that.
Oh, thank you, Kim, but you might be biased.
Kylie did ask if
second client goes there. Is that one? It's a great service, it really is, and the clients' feedback, it's really heartwarming. They feel so welcome. It's a great service, and it's a really effective service.
Thanks, Kim.
Thank you, Kim.
With the B12, there's a variety of protocols out there. We don't have our own. I think we're using one from South Australia.
Oh, the B12. Yeah, it was I can't remember where it came from. Or is it the Austin University one? No, that's the.
I think the GHB
the barbiturate
one.
Protocol.
Yeah, the phenobarbiturate protocol that we use is from Austin, but that's another story. Not an outpatient one. But the B12 I think is a South Australia protocol. I still have to look it up. It's just B12 3 times a week until you think they're better, I think.
All right. Well, I think we're coming close to the end. So I just want to add my voice to the comments here about what a fantastic service. And it strikes me that for this to work, it does have to be flexible. You've got some very experienced senior clinicians, and you make it easy for patients too. You've got on-site pathology pharmacy. You're giving that first week of medication. And I think that's sort of the lesson that I've really taken out of this as to how we could improve and expand on things that we're doing, because I'm sure there's a lot of people getting access here that otherwise just wouldn't or couldn't or would be falling through the cracks. So thank you very much to Dr. Stacey Weedon and Dr. Craig Sadler for joining us this evening and presenting on the service. I will call the meeting to a close now, and thank everyone else for joining us on a Wednesday night. and particularly for our presenters who look like they may still be in the office, maybe one or two more patients
Yeah, thank you.
to see, hopefully not.
We thought the IT is more likely to work in the office than at home.
Yeah, it depends with New South Wales Health Computer sometimes. I shouldn't say that in case there's any representatives from the industry.
Thanks for the opportunity.
Thank you very much. Yeah, and have a great evening. Everyone, we'll see you next time as well.